Okay, welcome back. I am so pleased to present to you our last speaker of the day. Dr. Timothy Vollmer is a colleague and mentor to me here at the university and the Rocky Mountain MS Center. He is a neuroimmunologist who is esteemed worldwide, and we're very fortunate to have him here today to talk specifically about research in this area. Immediately following Dr. Vollmer's talk, I will ask Anastasia and Dr. Qureshi and Dr. Schofield to come forward, and then we will be available to answer any remaining questions that you might have from the afternoon. So without further ado, Dr. Vollmer.
Thanks, Terry. I'd like to, I'm sorry, let me just turn this off here. It's bad manners, isn't it? Okay. I'd like to thank Terry and the Transverse Myelitis Association for inviting me to participate in this seminar, and also admire you all for your stoicism and being able to stay in this room all day on a beautiful summer day. I've had the pleasure of interacting with the Transverse Myelitis Association off and on, I think, over the last 20 years. It's and they allowed me to participate in a couple of their programs earlier on some time ago. So it's a pleasure seeing them back on campus here. So what I'd like to do is just really briefly tell you a little bit about the program here, talk a little bit about the breadth of the research programs here, mostly on the clinical side, and just make a couple comments about where I think some opportunities are going in the future for this group of disorders. I did it the right way. So a brief history of the Rocky Mountain MS Center. It was first established in 1978 by Dr. Jack Burks here at the University of Colorado, along with Darren Ryder, who was a gentleman that local philanthropist that unfortunately had MS. It moved in 1988 to the Swedish medical campus and remained there until 2008, when several things happened. One, the Rocky Mountain MS Center was looking for a new medical director and invited me to come back. The university was kind enough to offer me a position here, and I had a chance to join forces with Dr. Corboy, who had been here since, I think, 1992. John and I just envisioned building an MS program. We didn't realize was how it was going to explode and bring people like Terry and Augusto and Enrique and all the other people out, and it continues to grow very rapidly. So the Rocky Mountain MS Center is a two-part organization. So there's a nonprofit 501c that sits up in Broomfield, and then there's the clinical program, which is basically based here, as well as the KDEP program, which is an adult day enrichment program that's in Broomfield area. And that's been an old program that cares for particularly younger adults with neurological disorders like MS, transverse myelitis, et cetera. We collaborate with the Rocky Mountain MS Center to do education programs. We do over 20 education programs for patients and families, as well as many medical education programs. So this collaboration has really led to an explosion of neuroimmunology. So neuroimmunology, as you all know, is a subspecialty in neurology that focuses on inflammatory disease of the nervous system. And right now, we have 7 neurologists in the program, with an 8th one arriving next month. We have 4 advanced practitioners, and we have 4 clinical sites. So we have the large program here at the university, but we also have a clinic at Denver Health, a clinic at the VA hospital, and a clinic in what's called the Metropolitan Community Provider Network, which is a network of providers that serves uninsured and Medicaid patients outside of the Denver County. We have over 7,000 patient visits here on the university, another 3,000 patients in the research clinic, so we have over 10,000 our patient visits per year. These are about 85 to 90% MS, and the other 10 to 15% are transverse myelitis, neuromyelitis optica, and other rarer diseases. And only 22% of our patients actually come from the Denver area. 78% come from outside this area, including from both coasts and Asia and other places as well. So it's grown into a rather remarkable program, not due to me, but due to the other people around it. So a little bit about our research programs. This is just a listing of clinical trials that are currently open for enrollment or were recently open for enrollment. At any given moment, the Rocky Mountain MS Center has between 25 and 35 active studies. Right now, I think it's 29 active studies. And they include things such as this therapy up here, this RHI-GM-M22 antibody, which I'm going to talk a little bit more about, which is a monoclonal antibody that's trying to induce repair in the nervous system by inducing remyelination. This is currently being studied in patients with acute MS relapse, but it's very relevant to transverse myelitis and acute disseminated encephalomyelitis in the future. We have a biorepository, including a CSF bank, where we collect biological specimens in MS and the other related inflammatory conditions, as well as healthy controls. And this is rapidly growing to be an incredibly valuable resource that we can use, not just for our research, but to collaborate with many other investigators around the world, and in fact we do. We have ongoing volumetric studies in looking at brain atrophy. So this is particularly relevant to ADEM, acute disseminated encephalomyelitis. We're trying to understand just what happens chronically in the brains of patients that have these inflammatory diseases, and specifically in MS, because brain atrophy is the leading cause of disability in that disease, and we're beginning to understand it in other areas as well. You've already heard about the NMO studies. There are 4 studies going on in NMO under Jeff Bennett, and that program continues to grow. And then we also have a brain bank. It's funded by the National Society. It's been present for a couple of decades now. Dr. Corboy leads that, and that's another collaborative resource that we use to collaborate with other investigators around the world. Terry has done an outstanding job of developing the pediatric MS programs, and then we have studies looking more at immunology, and I'm going to talk about those just briefly. So there's one concept here that we've been promoting around the world in central nervous system diseases, and this is the concept of trying to maximize lifelong brain and spinal cord health through optimal management of the disease combined with adopting a healthy, active lifestyle. I'm going to briefly tell you why that's important. So there's a concept of brain reserve, or it could be called neurological reserve. It applies to the spinal cord just as much as it does to the brain. So in this context, I'm using the concept of brain reserve or neurological reserve to represent the capacity of the spinal cord or the brain to actually compensate for injury. So there are times when these diseases initially present that they're affecting the spinal cord or the brain, but the patient doesn't yet know it. They don't yet have symptoms. And that can go on for some time. Particularly MS as an example, they can have inflammatory disease for a decade before we actually recognize it. And unfortunately, that is causing damage to the brain, ultimately does have an impact on their long-term outcomes in terms of disability. So it does have this ability to do this, and reserve is something that is inducible. In other words, we use the term cognitive reserve, I don't know the master, to refer to the part of your brain's ability to compensate for injury that you can actually induce by being physically active, by being intellectually active, and by avoiding other health problems such as diabetes and hypertension that also can damage the brain and increase the disability from something like ADEM or transverse myelitis. And so we have a number of studies going on trying to help document this and conceptualize it with volumetric MRIs. We also lecture about this around the world, and we're working hard to get the rest of the world to understand the relevance of this to the treatment of these diseases. This is from MS because the diseases you're interested in here are quite rare, but it does demonstrate that there is something to this. So the first corner up here is just stratifying patients by brain size, or the intracranial size, so the size of the brain, with their cognitive performance on a few different cognitive tests. And you can see the larger the brain, the better the performance score. This is with MS patients. So this is looking at patients with relatively large brains versus patients with relatively smaller brains, and looking at their ability to compensate for increasing MS lesions in the brain. And so what happens, you can see, is that the larger brains are able to compensate for increasing damage to the brain without loss of function. On this side over here is looking at the what I mentioned as cognitive, the inducible part. So here, they're demonstrating that patients that have an active lifestyle, now controlling for brain size, so brain size is not the variable, it's having an active, healthy lifestyle, compensate or do better on this cognitive test, and also compensate better for increasing T2 lesion load in MS. This is exactly the same thing for acute disseminated encephalomyelitis. Oops. Come on. It's a little bit slow here, and I'm a little fast. Okay. And this is just a more recent paper demonstrating the same thing, that if we can help preserve brain volume, that can have an impact on long-term outcomes. The concept here that I guess I'm trying to get across is that in this group of diseases, when you damage the nervous system and you take some function away, the nervous system compensates for that, and you have some level of function. That level of function, though, may continue to slowly decline over time due to the effect of aging. So aging is also causing us to lose some nerve cells. And this neurological reserve or cognitive reserve is has developed, or at least allows us to age normally. So normally people can move into their 70s and 80s before they really have significant cognitive function. But with these neurological diseases, that uses up some of that brain reserve, and so the effects of aging become apparent earlier. And there's some therapeutic implications to this. So I'd like to just talk about some new opportunities and where we may be able to go in the near future. This is a list of reparative and neuroprotective therapies. It's not a complete list, but it is a list of things that either have been tried or considered for human trials. So first off, we have the stem cells. So there are several different kinds of stem cells. Obviously, we've spent most of the public's attention on fetal stem cells, but actually most research now is done with either bone marrow or what are called mesenchymal stem cells, which we can take out of the blood, or neural stem cells, which can be isolated from patients and grown in the Petri dish and have been used in at least one clinical trial. There's also a new type of stem cell called the inducible pluripotent stem cell, which is, I think, very attractive for us therapeutically. This is where we can take a cell from you. It could be a cell from your mouth, a cell from your blood. We can even isolate sloughed epithelial cells from the urine and grow them in culture and then treat them with certain factors that cause those cells to de-differentiate and turn back into stem cells. And then you can take those stem cells with factors that cause them to grow into nerve cells or oligodendrocytes or other types of cells. And the neat thing about that particular technology, it means that these cells are from you, so they match you, so they're not going to get rejected. They also, because they're from you, we don't have to worry about transmission of infectious diseases. And the other big advantage of these cells is you can go back and regenerate them over and over and over again. So one of the problems with stem cells is that as you grow them in the Petri dish and expand them to get enough that you can do something with clinically, they change. And that makes it very difficult to get FDA approval to go into human studies. But with inducible pluripotent stem cells, you can just induce them, put them through an X number of cycles, implant them, come back later, do the same thing again. So it allows you to have a therapy that you can do over and over again. There also has been development of a number of monoclonal antibodies. This includes the anti-lingo antibody and this antibody called the Rodriguez antibody that I mentioned earlier. So these are monoclonal antibodies that have been generated in the case of anti-lingo to target a specific signaling pathway that's very important to allow oligodendrocytes to grow and make myelin and insulate the nerve fibers. The Rodriguez molecule was found just by doing a broad survey of antibodies, and it's not exactly clear how it works, but in the animal model it does seem to induce remyelination. Now the anti-lingo, in the case of MS, looks like it's failed its phase 2 trial, so I'm not sure what its future is. The M22 molecule is in clinical trials right now here at the university as well as elsewhere, and if it goes well through this first stage, then it may be something that we can begin looking at in ADEM and transverse myelitis in the future. But I think the really exciting thing is over here. So these are molecules that have been identified recently either in clinical trials or in vitro models or in the animal model to have the potential to either induce remyelination or to induce neuroprotection. So in the case of remyelination, those are therapies that we could possibly use in patients that already have injury, and we're trying to make them better. In the case of neuroprotection, it offers the opportunity that if we can diagnose these disorders early and intervene early by adding these therapies to some of the other things that we use, we might be able to minimize the amount of residual damage to the nervous system and improve outcomes. So just briefly, and I'm not going to go through all of them in any detail, biotin is just a B vitamin. You can buy it over the counter. It was studied in Europe, meaning in France, in multiple MS patients and had some evidence that it helped improve outcomes in patients with secondary progressive MS. There are now 2 randomized clinical trials going on. One of them were one of the sites in one of those trials. These other medications here are drugs that are approved for other purposes, particularly clobetasol, which is a corticosteroid that you can buy over the counter to treat psoriasis or eczema. Miconazole is an antifungal agent that you can buy over the counter in a cream to treat fungal infections superficially. Guanfacine fumarate is a atypical antipsychotic drug that we use. Benzotropine, this appears a histamine receptor agonist or antagonist. Laquinimod is a drug I've been working on for more than 10 years. And then these drugs down here are approved either for hypertension and this one for seizures. So the point is that these have evidence that they may be useful in MS And because they're already approved, it means we can get into significant phase 2 clinical trials very quickly. And in fact, all of these are being considered somewhere as a treatment for demyelinating diseases or trying to induce recovery of function and prevent further progression of disability. To briefly go back to this model, which you've seen many times, immunological research in the treatment of ADEM, transverse myelitis, and MS has been primarily focused on the immune part, the T lymphocytes and the B cells. And you've heard a lot about B cells and how important they are. These therapies that I'm talking about are actually affecting these cells here, astrocytes, and also potentially directly the neurons and the oligodendrocytes. So again, this begins to offer an opportunity to really try to get to the next level of outcomes, to improve outcomes by combining the immunological therapies with some of these other agents to see whether we can really improve long-term outcomes and function. So you've already heard about the role of B cells, and I'm not going to go into any depth. As you know, that B cells can do a number of different things. Most physicians are familiar with their function in producing antibodies. They also produce hormone-like substances that affect their surroundings. But the other thing that they can do is be an antigen-presenting cell. In other words, they can take a molecule and expose it to the immune system to generate a very powerful immune response. These B cells come from the bone marrow. They move from the bone marrow into the lymph nodes, where they then are put into what's called lymphoid follicles. There they continue to mature and change the antibodies on the surface to make it more effective at binding whatever the target is. But these cells also get out into the blood, and they can enter the brain, where they can promote inflammation, ADEM, transverse myelitis, MS. And these B cells in the brain appear to be related. In other words, Dr. Bennett and others have genetically analyzed B cells from the brain and demonstrated that they appear to come from a single clonal founder, a single cell. So this is a very powerful bit of biology, and I want to just mention why that is, but I'm going to come back to one thing here. So I pointed that we think these B cells actually, the cell right here is probably the single most important cell in MS. And we've developed technology to be able to study that we can now apply to ADEM and transverse myelitis. This is an example. This is in collaboration with Dr. Wendy Macklin here. And what we have is we have a slice of a mouse brain in a petri dish where it's actually continuing to grow and make myelin. And so we use this to test whether the B cells from MS patients alone could actually damage the brain. And so just to walk you through this is what the brain slice looks normally. And these are the myelinated fibers, and these are in this case, microglia, in this case over here, the oligodendrocytes. So it's a way to actually quantitatively assess the amount of myelin and the amount of myelin-forming cells. Normal patients, if you take 100,000 B cells and put them on these plates, they really don't do anything. They look exactly the same. But when you do that with MS patients, they destroy the myelin bundles, so you don't have these bundles anymore. And if you actually look at the density of the oligodendrocytes, most oligodendrocytes have been depleted from these. So the B cells alone in MS appear to be able to drive the demyelination and the inflammation. And so we're using this model to continue to sort of focus down through and understand exactly what B cells do this and how they do it. And that offers additional opportunities for therapeutic intervention. But this is also something we can apply directly to ADEM and transverse myelitis as well. And so we're moving in those directions as well. So one last thing, just to emphasize how far we've come in MS and why this is relevant to these diseases. When I was trained, we were taught that the brain was an immune-privileged organ. It was different than other organs because the immune system didn't have routine access to it, and it didn't contain lymphatics. Now, as you all know, lymphatics are like the blood vessels. They run in parallel to blood vessels, but they basically transport fluid out of your tissues back into the circulation. But they do that through connecting with the lymph nodes in your body, so it gives your body a way to survey all the inside of your body immunologically and can mount immune responses to it. Well, it turns out last year it was discovered that human brains actually do have lymphatics. So these are these small tubes that connect the cerebrospinal fluid to the immune system. And they do that by actually connecting with the deep cervical lymph nodes. So these lymphatics run along the blood vessels. They go out through the openings in the skull with the blood vessels, and they feed into lymph nodes that are at the base of your skull, right at the base of the skull. And recently, a group from Yale has been able to demonstrate that these B cells, that they can demonstrate that there are B cells in these cervical lymph nodes that are from the same family as the B cells in the brains of MS patients. So this is an example of that. So if they took B cells from the brain. They did deep sequencing, genetic sequencing of their B cell receptor. And then they compared that to B cells from the cervical lymph nodes and found that the members of both families are the same families in both places. And they're proliferating more rapidly in the cervical lymph node. They did not find these B cells in lymph nodes in the chest. So we now know in MS that there are B cells being driven in the cervical lymph nodes that then have to go into the blood, through these lymphatics, circulate to the brain, might cross the blood-brain barrier, and then cause the inflammation. And that has led to the most effective therapies we've ever had in MS. And one is natalizumab, or Tysabri, which blocks the ability of B cells to cross the blood-brain barrier. Up until recently, that was the most effective therapy we'd ever studied. And now we have the ocrelizumab. And ocrelizumab is an antibody that actually kills B cells. And you heard about them this morning, so I don't need to go through them. But these are just different targets that we have. So in MS, we have moved ahead in a major way. This drug is going to revolutionize MS, but it also lays the foundation for us thinking more carefully about how to treat particularly the other inflammatory rare diseases that we see. We currently have 14 FDA-approved immunological therapies for MS. We have another 20 or 30 that are approved for other disorders. So we need to be able to organize studies in ADEM, transverse myelitis, and other disorders to see whether these drugs that are already out there could be used effectively to decrease and minimize disability and improve outcomes. And then the one last comment I would make is that the other thing that we desperately need in this area in particular is ability to make the diagnosis of NMO, transverse myelitis, ADEM faster and to implement treatment earlier. Unfortunately, the healthcare system is such that when you develop symptoms with these disorders, your first place you're going to go is most likely to the emergency room. And even if you go to your primary care physician's office, they're going to send you to the emergency room. And the emergency room is very good at treating certain acute disorders, such as heart attacks, myocardial infarction, and strokes. But these diseases, they tend to start the diagnostic workup, admit the patient to the hospital, the team's around, and it takes 2 or 3 days, sometimes a week, to get a diagnosis and to initiate treatment. And that's lost opportunity. If we could diagnose these in the ED and treat them like we would stroke, we could dramatically improve the outcomes just with the therapies we have now. And it also would give us the ability, if we set up a network that could do this, probably through telehealth, then it also means that we could begin to implement additional trials and studies of some of these other agents that may have promise and usefulness in this particular disorder. Thank you.